Huntington's disease HD is a progressive neurodegenerative disorder characterized by the gradual onset of motor dysfunction, cognitive decline, and psychiatric disturbances. The disease is caused by an autosomal dominant mutation in the HTT gene, which leads to an abnormal expansion of CAG trinucleotide repeats. This mutation results in the production of a mutant huntingtin protein that is toxic to neurons, particularly in certain brain regions, leading to the hallmark symptoms of the disease. Genetic basis and pathogenesis. The HTT gene, located on chromosome 4, typically contains 10 to 35 CAG repeats. However, in individuals with Huntington's disease, the number of repeats exceeds 36, and in more severe cases, it can be over 60. This expansion leads to the production of a mutant huntingtin protein with an abnormally long polyglutamin tract. The length of this tract is inversely correlated with the age of onset of the disease. The more repeats present, the earlier the onset. The mutant huntingtin protein undergoes abnormal processing and tends to misfold, forming aggregates that accumulate in neurons. These aggregates are toxic, leading to neuronal dysfunction and death. While the exact mechanisms of toxicity are still not fully understood, it is known that the mutant protein disrupts several cellular processes. These include transcriptional regulation, mitochondrial function, axonal transport, and synaptic transmission, all of which contribute to the neuronal degeneration observed in Huntington's disease. Affected brain regions. The pathology of Huntington's disease is most pronounced in the basal ganglia, particularly in the striatum, which includes the caudate nucleus and putamen. These regions are crucial for the regulation of movement and are involved in a wide range of cognitive functions. The loss of medium spiny neurons, which are particularly vulnerable to the mutant huntingtin protein, leads to the characteristic motor symptoms of HD, including chorea, involuntary, jerky movements, dystonia, muscle rigidity, and bradykinesia, slowness of movement. As the disease progresses, neuronal loss extends beyond the basal ganglia to other parts of the brain, including the cortex, leading to more widespread cognitive and psychiatric symptoms. These can include memory loss, impaired executive function, depression, and changes in personality. Molecular and cellular mechanisms. At the molecular level, the mutant huntingtin protein exerts its toxic effects through several pathways. Transcriptional dysregulation. The mutant protein interacts abnormally with transcription factors, leading to altered gene expression. This disruption affects the production of essential proteins, contributing to neuronal dysfunction. Impaired protein degradation. The presence of mutant huntingtin interferes with the normal functioning of the ubiquitin proteasome system and autophagy, which are critical for the degradation of misfolded and damaged proteins. The accumulation of mutant huntingtin and other proteins leads to cellular stress and death. Mitochondrial dysfunction. Mutant huntingtin has been shown to disrupt mitochondrial function, leading to energy deficits, increased oxidative stress, and the release of pro-apoptotic factors that contribute to neuronal death. Synaptic dysfunction. The abnormal protein impairs synaptic function by disrupting neurotransmitter release and receptor activity, leading to impaired communication between neurons. Clinical manifestations. The clinical presentation of Huntington's disease varies but typically begins with subtle changes in mood, cognition, and motor skills. Early signs may include irritability, depression, and minor involuntary movements. As the disease progresses, motor symptoms become more pronounced, with chorea being one of the most recognizable features. Cognitive decline also accelerates, leading to difficulties in planning, organizing, and executing tasks. In the later stages of the disease, patients may experience severe motor impairment, speech difficulties, and significant cognitive decline, often resulting in total dependence on caregivers. Current research and future directions. Despite the lack of a cure, research into Huntington's disease is ongoing. Current therapeutic approaches focus on managing symptoms and slowing disease progression. These include medications to control movement disorders and psychiatric symptoms, as well as physical, occupational, and speech therapies. In recent years, gene therapy and RNA-based approaches have emerged as promising strategies. These therapies aim to reduce the production of the mutant huntingtin protein or to correct the underlying genetic defect. For example, antisense oligonucleotides (ASOs) have shown potential in lowering the levels of mutant huntingtin, offering hope for slowing or halting the disease progression. Conclusion. Huntington's disease is a devastating disorder with a profound impact on individuals and their families. While much has been learned about the genetic and molecular basis of the disease, significant challenges remain in developing effective treatments. Ongoing research into the underlying mechanisms of HD and the development of novel therapeutic strategies offer hope for better management and, ultimately, a cure for this debilitating condition.